A middle-aged patient presents with recurrent bouts of pneumonia, each time affecting the same region of the left lower lobe. Despite antibiotic treatment, the symptoms persist, leading to further imaging investigations. On the chest X-ray, the left lower zone reveals multiple fluid-filled cavities. This finding immediately raises concerns for an underlying structural abnormality or chronic infection. Moving on to the CT scan, it becomes clear that the left lower lobe is consolidated with multiple air fluid levels, indicating a necrotic process or chronic infection. These findings are highly suggestive of pulmonary sequestration. Pulmonary sequestration is a rare congenital anomaly where a segment of lung tissue is not connected to the normal bronchial tree and is instead supplied by an aberrant systemic artery, often directly from the aorta. This abnormal segment of lung tissue is prone to recurrent infections due to its isolation from the normal airway system, as it cannot properly drain mucus and other secretions. There are two types of pulmonary sequestration: intralobar sequestration, ILS. This type is more common and occurs within the normal lung tissue without its own pleural covering. It often presents later in life, as in this patient, and is prone to recurrent infections. Extralobar sequestration. This type occurs outside the normal lung and has its own pleura. It is typically diagnosed in infancy or childhood due to associated congenital anomalies. The key diagnostic feature for pulmonary sequestration is identifying the aberrant systemic arterial supply, typically from the aorta. This can be visualized with advanced imaging techniques like CT angiography or MR angiography, which play a crucial role in confirming the diagnosis. In terms of management, surgical resection is often recommended to prevent recurrent infections. In some cases, minimally invasive approaches such as coil embolization have been trialed successfully, particularly in patients who are not suitable for surgery. Additionally, in rare cases, spontaneous involution of the sequestration has been reported, though this is quite uncommon. When evaluating this case, it's also important to consider differential diagnoses such as necrotizing pneumonia. A similar presentation with cavitation and consolidation could occur, particularly in chronic infections. Bronchogenic carcinoma with necrosis. This can present with cavitation, but it is less likely in a patient with recurrent infections in the same region over time. Pulmonary sequestration was first described in 1946 by Price, who coined the term. Though rare, it's essential to recognize it early, as it can lead to significant complications, such as frequent respiratory tract infections, and in neonates, even high-output cardiac failure. This case beautifully illustrates the importance of correlating recurrent infections with congenital anomalies and the critical role of imaging in detecting these rare conditions. Thank you for joining me in this deep dive into pulmonary sequestration. If you enjoyed this discussion and want to hear more cases like this, don't forget to subscribe to Radiology Made Easy. And if you'd like to support us in continuing to provide these insightful discussions, check out the Buy Me a Coffee link in the description below. Your support makes all the difference. See you in the next case.